Hi, everyone. Good evening, and welcome to the Henry Schein Dental Academy webinar series. My name is Corinne, and I will be your moderator. We are excited to welcome Dr. David Wong, leading clinician, influencer, and renowned lecturer as our speaker tonight. He will be giving an insightful look at bone grafting techniques and procedures and how CBCT aids in the overall treatment planning process. Before we get started, I do have a few housekeeping notes for you. At any point during the webinar, if you have questions, please type them into the Q&A section of your control panel, and we will answer them live at the end. All right, that wraps up our housekeeping. Dr. Wong, looking forward to your presentation. I will pass it on over to you.
Hey, everybody. I'm just answering a fellow OU Sooners message here on the chat. Anyway, thanks for using the chat for questions and stuff. We're going to be using that towards the end of this. Today, it's a pleasure and honor to be back with Henry Schein to give you guys another webinar. We originally planned this as just a 1-hour webinar called the No Nonsense Guide to Bone Grafting, but I've talked him into letting me do a 2-part series here. For those of us who are beginners, for those of us who are more intermediate to advanced, bone grafters, I just kind of wanted to give something for everybody and not leave anybody out. So this is going to be part 1, where we're going to talk about dental materials, bone grafting materials, membranes, when you need one, when you don't, and that type of thing. For part 2, we'll get into more of the bone augmentations, more of the CBCT and surgical guides and all that stuff. And if you guys like, just write to Henry Schein, let them know, we want more of this stuff. Just let me know what you guys want to hear, and I'm happy to teach you whatever I know. So with that being said, let's go ahead and get started. After today, if you guys have any questions or anything, please message me. Instagram's probably the easiest. My main Instagram account is david.wong.dds. And if you guys like surgery stuff, you guys know to follow me at Plaque China. So looking forward to interacting with you guys there as well. So today, this is a little bit new because I know we're talking a lot about dental implants nowadays. And with Henry Schein, I've been working with them a lot on the digital workflow and CBCTs and scanners and all that stuff. But what we really need to figure out is why do we do all this stuff? What's with all the technology? We practiced forever with implants and things without technology. So why all of a sudden is there this big push for everybody to get a CBCT and a scanner? So in my practice, being a periodontist, one of the most useful things that I do is implants. Single teeth is what I do most. So as an example, in a situation like this, we're going to replace tooth number 9. And I think a lot of people, when they learn implants, they get really excited about the possibility of placing an immediate implant. So in a situation like this, I would tell you, if you're going to take out a central incisor or any front tooth and put an immediate implant in, it's going to be imperative that you have that CBCT, so that you can, prefabricate these temporaries and deliver them to your patient accurately without spending all day in the chair. And if a lab, that you work with has access to your digital files and things, they can plane your implant. We're going to go over all this, throughout this whole 2-part series to make sure that that implant is dead straight and the temporary is fabricated seamlessly and effortlessly for you. The reality of it is most of us don't start off in implants, taking out a tooth and sticking an implant in. Most of us, start off, walking or crawling before we walk, right? So we're going to talk about bone grafting today. And the reason we talk about bone grafting, before implants instead of the other way around, is that I commonly see the people who start the other way around with immediate implants and learning how to put in screws before they learn about the bone, is a lot of times we'll end up with cases like this in our chair. So this is a case that popped into my office several years ago, and I follow up with her all the time just to see, where she's at, emotionally, psychologically, clinically, what is she up to? So here's missing tooth number 8. And you guys are probably asking, what's the problem? I mean, maybe the soft tissue is a little bit flat. What's the big deal with tooth number 8? Well, the problem is she's wearing a flipper and she just isn't eligible for anything else right now because this is what we're dealing with clinically. We're dealing with this tooth, or now implant number 8, where the implant's placed, too far to the buccal. And now we're stuck. We've been stuck for the last few years, trying to advise her on what to do, because honestly, there really is no good solution. So, and this is her. I mean, you can tell I've got her eyes, kind of blacked out, but you can tell, I mean, this is a young, attractive woman. She cares about her smile. Obviously, she's got the Invisalign going on the bottom, but this is not good, So what do we do in a situation like this? So my goal is to teach you all how to crawl before we walk and how to walk before we walk and run. So we're going to talk about how to manage the bone. I treat cases like this all the time, and if you guys want more information about this, I'm happy to do a presentation on implant complications. But today we're talking about recession around some of these implants that could have been avoided if we would have used the right technology, like a CBCT or a surgical guide, or just learn more about how to manage the bone. So these are all the types of cases that I'm hoping that you and I both avoid in our practices, because as you can see here, if you can imagine, these are not easy cases to treat. Even if you were to say, to heck with it, take the implant out, that's no easy feat once an implant's already integrated into the jaw. So let's talk a little bit about implant site preparation today. That's really kind of where we're going to go. And the purpose of all that is going to be, so whenever we place our implants in the aesthetic zone, we want them to be as aesthetically pleasing as possible. And that's kind of the goal here. So what we're eventually going to strive towards in this two-part series is going to be, how do you manage, cases like this tooth number 10, where you have a blown out, facial and lingual plate. Maybe this lesion encompasses, some other teeth as well. How do we manage those? I'm going to teach you guys how to diagnose this type of a case, as far as, how to diagnose the socket that you're going to be dealing with, how to recommend, the proper materials, incision and flap design, how to suture it. We're going to go through all that, throughout this two-part series. So once again, I want us to avoid these types of complications where, the implants, way too shallow, blown out the facial plate. And now how do we fix this? So, and I get these cases all the time. This is another attractive young woman. She's a dental assistant, and implants just have not been kind to her. In a situation like this. So where we're headed now, and what we're about today, is going to be, how do we take these types of cases where, if you look above number 7, there's that fistula tract up there, and then when you take the teeth out, you can see that we've got blown out facial plates. This is the goal, is knowing what to do when we're presented with this type of a case, not necessarily being, aces at it, the first time we try it, or maybe not even the second or third or fourth time we try it, but eventually, learning to master this technique, or at least knowing, what, maybe this isn't for me, So at this point, I'm going to teach you how to manage these cases to where, 6 months later, you start from blowing out, facial plates after the extractions to all this bone to where you can place your implants, in really good positions, good spacing, with plenty of bone to the facial aspects, and we're not going to get recession. So the goals for this presentation today, we're going to start off providing a rationale for socket grafting. That's probably the most underutilized technique or procedure that I see in implant dentistry, is people take teeth out and they don't think far enough ahead to graft the socket and prepare the site for an implant. Usually they treat the toothache by taking the tooth out and just take it out. And then later on, they're thinking, oh, the patient now wants an implant. So this is just something that we need to talk about. I'm going to talk to you about the 3 different types of sockets and how we treat them differently. It's going to go from very, very easy to a little bit more complex. You guys are going to leave this hour knowing the principles of bone grafting. There's 4 basic principles. We're going to talk about how to choose a bone graft material, and how to determine when you need a membrane and when you need primary closure over that membrane. So this is one of my favorite quotes in all of dentistry. This is from Harry Clinda, the former ADA president. He said, "There's a great deal of difference between a dentist with 10 years experience and one who has repeated the first year 10 times." So I really want us to think about that, because a lot of times, especially when we're talking to, personally for me, I talk to dentists from all different experience levels and different ages. And one common thing that I hear all the time is, we've always done it that way, or I've been doing this for X amount of years, why change now? Socket grafting is not new, but it's very, very, very much underutilized. What is socket grafting exactly? It's the placement of a bone replacement graft in an extraction socket at the time of the extraction. Now, I usually say it's at the time of the extraction. On occasion, you can do a delayed approach, but for the most part, we're talking about taking the tooth out, grafting the socket at the same time. So the first question we have to ask is, what happens to the bone once a tooth is removed? So when you look at the studies and the research, and this is very beautifully summarized in a very simple paper by Gordon Christensen, it's a 2-page paper. Tooth loss creates 40 to 60% bone loss in the first 2 to 3 years after the tooth is removed. And then you continue to get a resorption rate of 0.5 to 1% for the rest of your life. So it doesn't ever stop unless you put an implant in, right? So because you don't have that stimulation of the jawbone. We also know that bone grafts at the time of an extraction are very important for making sure that we have high quality of bone, to place an implant in. We know that if you just let the graft, but if you just take out a tooth and let the socket heal in by itself, you get a mixture of both bone and scar tissue or connective tissue. I'm going to show you some proof of that here in a second. So take this case for an example. In the old days, people would say, I take out this tooth. I'm so good at taking out teeth. I left the facial plate because I've got nice, delicate hands. The facial plate's intact. I don't need to graft the site. Well, the truth of the matter is 3 months later, when you look at it, that bone's going to disappear. And the reason it does is several reasons. The main reason is because you lose the blood supply to that thin piece of bone. And once you lose that blood supply, it's going to disappear on us. I don't want to go too heavy into the research, but I do want to give you some. That way, I'm not just trying to sell you a product or just, blow smoke up your butt there. We're trying to really present a case for socket grafting whenever it's appropriate for dental implants. So when we look at this case, this paper from Meyer and Nevins, it really focuses on the fate of the buccal wall. And what he did in this paper, obviously he took out teeth, but half of them he grafted the socket, half of them he didn't. And in the half that received a bone graft, 79% of them had less than 20% bone loss. The half that didn't get a graft, 71% had more than 20% bone loss. So clearly we need to be grafting sockets if we care about the bone. The other thing that's important about this research is that just because you graft the socket does not mean that you're going to get 100% of the ridge preserved. You still lose, give or take 20%, because you can't preserve, no bone grafts preserve 100% of the space. So going back to the fate of the buccal wall here, specifically that thin piece of bone that you see on the labial aspect, that's what we call bundle bone. It's really delicate and it receives its blood supply from the PDL, the periosteum, and the alveolar marrow spaces, which is very, very thin to non-existent. So once that tooth is gone, this piece of bone is going to want to resort. And because you do tend to lose about 20% of your ridge width, some of these cases, especially in the front teeth, especially if they have a high smile line or a thin biotype, sometimes we have to add a little bit of a gum graft at the same time as well. So just kind of let this image burn into your mind. It doesn't matter how good of an oral surgeon you are when it comes to taking out these teeth. If that bone is less than 1 millimeter wide, it's going to go away. Clinically, what does that look like? Clinically, it looks like this. You take out a tooth, number 7, it's in the aesthetic zone, the bone's thin, it's going to cave in. Why should we care about that? We care about that because eventually the patient's going to want a tooth replaced. And rather than being able to just place an implant right now, we have to go through this whole process of a bone graft augmentation. We got to maybe consider some soft tissue augmentation and all this other stuff that makes it, sometimes not even worth it to patients. They're just like, I don't even want to do all that. It sounds too complicated. Cases like this, you can clearly see that these extraction sites were not grafted, and we have that huge labial concavity. So the bottom lines to why we socket graft is that we want to enable the placement and stability for our future implants. We want to reduce the bone loss. We want to reduce the need for additional bone grafting, like bridge augmentations, like I mentioned just now. We want to provide quality bone, because remember, we don't want that socket filled in with a bunch of connective tissue and scar tissue. We want to look good, and it can't look good if we have a labial concavity and a loss of soft tissue on top of that. Patients also want to get started faster. So if they're not a good candidate for an immediate implant, like I showed you earlier with some of those blown out facial and lingual plates, this gives us the best chance at regenerating the bone as fast as possible so that we can get a move on the implant and the final restoration. And finally, we graft some of these sockets because they're really close to some adjacent teeth that might be healthy. So by grafting these sockets, we protect the bone on the adjacent teeth. So as an example, look at number 29 and number 30 here, the second premolar and the first molar. Those teeth have got to go. But what happens to the bone on the distal 28 if you just take the teeth out and let it heal up? You're going to lose bone on the distal 28. So that's why, you know, a good place to start, by the way, this would be an awesome case to do your first socket grafts. What about this? Tooth number 30, you've got non-restorable recurrent caries. Tooth has got to go, but if you just let it heal up, you know, the bone is going to dip down. That's how it's going to heal up. And that's going to affect, you know, the placement location of your implant. It's going to affect how long of an implant you can place because of the mandibular canal down there. So this affects a lot of things. So we got to think ahead. In the aesthetic zone, this is what I was talking about earlier. You know, this tooth, number 7 here, it's so close to the central and the canine. You know, if number one, if the patient just lets this go and they're asymptomatic because the tooth has been endodontically treated, but if they let this go, they're going to end up losing more than one tooth. But number two, if you just take the tooth out and don't put a socket in, they're going to continue to lose more bone and get recession on the sides of those teeth. And I'm sure you guys have seen that before in your practice. What if we're not so gentle with our extractions? You know, what if we accidentally, you know, take a canine out and the labial plate comes out with it? You know, do we know what to do in that situation? Do you just leave the labial plate out? Do you put it back in? And these are all things that we need to talk about and have a conversation about, because it does, as you can see here, affect the aesthetics of the case. And it also may affect the adjacent tooth, just like that brand new crown that patient just paid for. And now it's got, you know, 3-4 millimeters of recession on the mesial surface. So when it comes to implant aesthetics, this is what we're trying to do. You know, I always tell, you know, doctors that I'm training, you know, patients come to us because they want teeth. You know, they don't really come to us asking for implants. They just tell you, I want a tooth. You know, I'm missing teeth and I want my teeth replaced. So the idea here would be to put in these implants where you can't even tell which ones are the implants. And just for your information, the implants here are number 6, 8, 9, and 11. So those are 2 3-unit bridges there. The implant here is tooth number 8. And I'm going to show you how to get there. I'm also going to show you how we got here. You know, this is tooth number 9. I didn't place this implant, but you can see, you can imagine the difficult conversation that you would have with this patient if they were to come into your office right after you placed an implant and restored it. They're not going to be very happy with you once you tell them that it's not a fixable situation. So the secret to growing bone is proper planning. So what we're going to look at today is going to be the type of extraction site that you have. I'm going to show you how to analyze what type of technique you're going to need based on how much labial plate you have. I'm going to give you a very simple solution on what to buy as far as graft materials. It's been my experience when people don't know much about bone graft materials, they tend to buy the cheapest stuff. And that's not the best way to do that. I'm not going to send you towards the most expensive stuff either. I'm going to send you towards the stuff that's worked for me for the last, since 2006. So for the last, 16 years or so plus, these materials have worked for me. We're going to talk about techniques. We're going to go over a technique and a half or two today. and then I'm going to save the rest for part 2. But the goal here is just to show you what can be done with some of these extraction sites from start to finish. Like you can see here, we can totally and predictably, grow the bone virtually every single time. So, choosing a bone graft. First thing you guys need to know is that there's 4 sources of potential bone that we can use. Number 1 is what we call the autograft, and that's where we use the patient's own bone. They don't particularly like that because that involves, going to, some other intraoral area like their chin or the ramus, maybe the tuberosity. We can also use extraoral sites such as their hip or shin. They're not really fond of that. So autografts work great. They're considered the gold standard. But for socket grafts, we're not going to use those. Where we're going to live and breathe today is going to be in the allografts. That's the cadaver bone. Okay, so it's coming from another human being, and it's going to be either mineralized or demineralized. Maybe you guys have familiarized yourself with these terms. The third option is because sometimes patients get kind of freaked out that with cadavers and stuff, they'll ask you to use something else like an animal. So sometimes we use a xenograft. Xenografts mostly come from cows or pigs, so bovine or porcine grafts. But it should be noted that sometimes it comes from horses, which is equine bone. Lastly, some patients don't want anything that used to be alive at all, animal or human. They'll want something synthetic. And that's where your alloplasts come in. Those are going to be like your ceramics and your glasses, your calcium sulfates, which is, plaster of Paris, just medical grade. So sometimes there's an indication for some synthetics as well. What patients need to know before that we get started is that bone grafts are effective. They're not very invasive, and it's the least expensive thing that they're going to do if they're thinking about implants. The worst thing they can do is just let it heal and shrink up and then change their mind later and want a bone augmentation and all this other stuff. That's going to be the most expensive decision they make when it comes to the implant treatment. They also need to understand that tooth loss results in faster and more severe bone loss than periodontal disease. But mostly what patients ask me about in the office is whether or not it's safe. And for me, whenever I'm talking to them about safety, I usually just keep a little bit of bone around in a jar, and I just show them. I just hand this to them like, look, it's just powder. It's not going to hurt you. It's freeze dried. It's been treated and sterilized and tested for hepatitis B and other antigens. That way you don't have to worry about catching a transmissible disease. And once they handle it and see it, and they're like, that's no different than just a jar of powder, that really puts their mind at ease. So what are the keys to predictable bone grafting? There's 4 S's of bone grafting that the way I like to teach it anyway. So there's 4 S's of bone grafting. The first S stands for surface. And what that means is you need to have a clean surface if you're going to grow bone to anything. If you have calculus on a root, you're not growing any bone. Same thing with plaque or biofilm or an amalgam or a subgingival, restorative margin. You're not going to get bone to those surfaces. So when it comes to extraction sites, you're not going to get bone growth if you have a pocket lining that we forgot to scrape out after we took out a periodontally diseased tooth. So we got to make sure that the socket is free from a bunch of granulation tissue and granulomatous tissue and things like that. The second S and the third S are very, very important. Your graft material has to be stable, and you have to maintain the space. So stable means you should be able to move their lip and cheeks all around, and that graft stays put. The space needs to be maintained, meaning we can't be having like a flipper partial, pushing on the graft and expecting us to grow bone. Last thing is proper suturing, and that sometimes people call that submersion, but I just say suturing. If you can suture it the right way, then you shouldn't have any problems. So the 4 S's of bone grafting: clean surface, you have to have good graft stability and space maintenance, and you got to suture it properly. Okay. The only other things you need to know is that you also need a good blood supply, like we talked about before, and you need a source of bone growing cells. So that's going to be abundant when both of these things are abundant when we're talking about an extraction site. So why do we start, when we talk about the no nonsense guide to bone grafting, why do we choose sockets first? Well, they're the most predictable. And they're the most predictable because you have an acute wound where you just took out a tooth and the socket is bleeding. That is way better than, for example, me as a periodontist trying to graft a really deep furcation. So the fact that you just took out a tooth and you have a bleeding socket gives you a huge advantage over a chronic wound like what you get in periodontal disease. You have a four-wall defect, which is awesome. You have a buccal, lingual, mesial, and distal wall. That's exactly what you need to be successful. Like I said, it's already bleeding, and you got PDL cells. You know, PDL cells are what's responsible for spontaneous bone growth when you take out a tooth and the bone grows in by itself anyway. Also, whenever you're grafting sockets, they're very easy to stabilize, maintain space, and clean because you're not having to dig around a furcation or something like that. And also, for the purposes of tonight, for part one, you don't even need to get primary closure. You need a figure-8 suture and you're done. So let's talk about the technique. So technique number one is what we call the basic socket grafting technique. And how this works is when you take out a tooth and we can count that you've got 4 walls of bone, facial, lingual, mesial, and distal. This works really good for teeth that are being lost due to non-restorable decay or a horizontal root fracture. It works the best if the patient is periodontally healthy. You know, they don't have a lot of perio disease, they don't smoke, you know, they don't have a lot of bone loss. These are the cases that are the best, and I'll show you an example. Armamentarium wise, super easy. You're going to buy whatever you can to take out a tooth atraumatically as possible. So for me, that means straight, and I use a curved periotome. I'll show you what that looks like. We're going to use a straight elevator, and you need your favorite extraction forceps for whatever tooth you're taking out. As far as the bone goes, super easy. You're not going to buy anything else but mineralized cortical bone, whatever brand you want, and I'll share with you what I use, but you're going to use mineralized cortical bone. Cotton tip applicators is what we're going to condense the bone with because it's cotton, so it'll absorb moisture while we're condensing. And then as far as sutures go, just use 4-chromic gut today. That's all you're going to need. Super simple. So let's go over an example. So we have tooth number 9 here. We got a horizontal root fracture, and we're going to use mineralized cortical bone to graft this socket. First thing we got to do though, after we choose a graft, is we got to get that tooth out, you know, nice and cleanly. But as far as, you know, whenever I just said you're going to buy mineralized cortical bone and nothing else, let me explain that for a second. Mineralized cortical bone, not only is it the least expensive of any bone grafting line, no matter what brand you use, it's also the most effective for grafting sockets because sockets are big defects. And for big defects, you need something that occupies space for a longer period of time, like 8 to 12 weeks. So in that situation, that's why you're going to use mineralized cortical bone. It's also easier to pack and condense when you're trying to get these particles into the socket. The only other thing you're going to look at is on the right side of your screen where it says mineralized cortical 300 to 1,000 microns. That's what you're going to buy as far as the particle size. So you're going to have lots of particle size choices. The reason we use 300 to 1,000 is because anything less than 300 is going to be so small that it gets resorbed by the patient's body. Anything over 1,000 microns gets fibrously encapsulated, so scar tissue forms around. So let's go back to our patient here. We got tooth number 9. So the way that I like to take out front teeth is this. I'm going to get a fresh number 15 blade. Some people prefer a 15C. It doesn't really matter. I like 15s. But all you're going to do is make a sulcular incision all the way around the tooth. That's step 1. Okay. Now, after you do that, your 15 blade, because your sulcular incision, by the way, is directed at the crest of the bone, and you're just going to walk it all the way around like you're probing the tooth, except you've got a 15 blade in your hand. You're going to probe this, aim towards the crest of the bone. After you do that 360 degrees, your blade will be dull, and that's good because you're going to use that now as your first periotome. And you're going to insert it on the mesial side of this tooth number 9, right into the sulcus. And you're going to push that blade into the PDL space this time, not the crest of the bone, but the PDL space. And you're going to wedge it in there and create some space. And you're going to let that sit there for a minute or two. And then you're going to take it out and you're going to do the same thing on the distal side. Okay. What you're going to do is try to create some space in the PDL space so that we can start to get larger instruments in there. After you do that, you're going to use your straight periotome. Okay. A periotome is basically like a blade. It's kind of between an elevator and a blade. The blade portion of it's usually like 0.5 millimeter in width and thickness. So you're going to do the same thing. You're going to introduce it on the mesial side and then the distal side. But this time around, you're going to do the lingual side as well. Because we had a horizontal root fracture, the top part of the crown just came off. So you're going to repeat those first few steps, going from your starting with your periotomes. And you're going to go mesial, distal, lingual. And once you get 270 degrees around that conical shaped single root, that whole thing will pop out. Okay. At this point, what you're going to do, you're going to observe that you've got a nice socket. You have intact papilla on the mesial and distal sides. We haven't over-traumatized the soft tissue. This is what it looks like from the facial. So the biggest thing here is just getting the tooth out without breaking that labial plate. And that's the key thing. After you do that, you're going to get your perio probe and you're just going to slide it into the socket and you're going to count how many walls of bone you have. If you have 4 walls of bone, meaning facial, lingual, distal, and mesial, then you're about 2 minutes away from being done. You're going to have your mineralized cortical bone in its jar already, and all you're going to do is sterilize, or not sterilize, you're going to hydrate it with sterile water or sterile saline. And that's what you're going to hydrate it with. Be sure you stir it around though, because if you just dump water in it, only the top part of those particles will get hydrated. It doesn't get to the bottom, so you got to stir it around really well. You're going to do that, let it sit there for supposedly 15 to 20 minutes. That's ideal. If you go in too early, then it gets kind of dry. It's hard to work with. So make sure that you hydrate it for a recommended time of 15 to 20 minutes. And then all you're going to do is put your bone graft material into the socket and condense it with your cotton tip applicator. I use it dry whenever we have a real, a bleeding socket, a patient with a lot of saliva, just because you're trying to condense this powder while blood and saliva is trying to get it to come out. So this cotton tip applicator is a real cheap and easy way of absorbing that moisture while you're condensing the graft. You're going to close out with the figure 8 suture, and you're going to provisionalize, preferably with an Essex retainer. Now, I say preferably because with Essex retainers, they're tooth-borne, so they don't put any pressure on the tissue at all, which is great. The most common thing I see is a flipper partial, which is fine as well, but you've got to make sure that you relieve the area above that's sitting on the graft. You don't really want any pressure on it. And you also want to make sure that you relieve the papilla area so it's not pushing the papilla down. Then you're going to take an x-ray. That's for insurance and record keeping purposes. You can send it on with your insurance claim or whatever you want to do. And that's what that's going to look like. The key thing here is you want to make sure that your bone graft material is sitting even with the proximal bone, not above it, because anything above it that's in the soft tissue, it's just going to fall out. You're going to allow, if you're doing a bridge or an implant, doesn't really matter, you're going to allow 8 to 12 weeks before you put your implant in or before you make your final impression for the bridge. Now, I'm in Tulsa, Oklahoma. There's a lot of times where we just still do bridge work. So if we're doing bridge work, does that mean we don't graft the socket? The answer is no. We still graft the socket. And the reason we do that is so that we can develop the ponic site so it looks good. So how do we do that? So in a situation like this gentleman, we're going to take out tooth number 8 and we're going to make a bridge, okay? Usually the dentist will have a temporary bridge already made for me. In this situation, he had already prepped the tooth. The tooth had broken off at the gum line, so he had already had a temporary bridge on. All I had to do is remove the temporary bridge and take out the remaining root, which is what I'm doing here. So the tooth is out. There's your socket from the occlusal surface. You can see it's a nice bleeding socket, perfect for what we want to do as far as socket grafting goes. And then we're just going to graft the top of that socket with bone. And then we're just going to reseat the provisional. Now you're going to notice with the ponic site, we make sure that the ponic design should be an ovate ponic. And we want to make sure that it goes subgingival by about 3 millimeters. And when we do that, what you're going to see here is by that time that's fully seated, by the time he comes back in 2 weeks, I didn't make that temporary bridge, by the way. By the time he comes back in 2 weeks, you'll see how that tissue is molding right perfectly around that ponic area. And the tissue is nice and healthy. And we've got preservation of the ridge dimensions, which is the intent of socket grafting. So if we look at this again, here we've got tooth number 6 that we're going to take out. We're going to keep number 5. So number 6 is extracted. We place the socket graft. Remember, we pack the bone even with the height of the interproximal bone so we don't overpack it. And then when we do that ponic site, make sure that goes subgingivally by 3 millimeters. This is for ponic site development. So if we do that, by the time we get to 12 weeks, you can see that this tooth doesn't even look like it's missing. You know, that's just the temporary, it's a 2-unit temporary bridge. And you can see that we even have what looks like a canine eminence on the facial aspect of that. So the question that I get from a lot of people is, how do I know that the bone wouldn't grow into the socket by itself anyway? They're always like, I used to take teeth out all the time and it always heals up beautifully. Well, let me show you this. Prime example, I had a doctor refer this case to me. He wanted me to do an implant on his patient for tooth number 19, sent me this PA, said, now look at the PA. I didn't even graft the socket. It looks great. And I was like, well, that's nice and all, but we need a CBCT. Like, what do you need a CBCT for? Well, we need a CBCT so we can look at this in 3 dimensions. And that's crucial because when you look at this radiographically, it looks great. When you look at this clinically, the bone looks this wide. It looks great. From the facial aspect, you can see that we lost a little bit of the facial plate, caves in just a little bit, but as you can see, it's still a wide ridge. So what's the problem? The problem is when you take a CBCT, you can see there where that root used to be. It has not filled in with bone. So try putting in your implant perfectly and getting good stability. I mean, it can be done, don't get me wrong, but clearly that patient is still going to need additional bone graft placed, that we still need to have a membrane and some soft tissue management there. These things are just a lot harder, you know, that unnecessarily complicated when a, you know, $60 or $70 bottle of bone could have saved us all this hassle. So before you do implants, I'm telling you, a CBCT helps you avoid a lot of these types of problems. So this is what it looks like closer up. So where's the bone? So once again, socket grafting virtually guarantees that we'll A, have enough bone there, but B, have enough good quality bone. So as far as post-op, you know, we'll talk about that here in a bit, but essentially you just treat these things just like regular sockets. You know, you don't need, just like you would take out a tooth, just to put a gauze pack in, have them bite on it for an hour till they stop bleeding. You're also going to notice in this case, so you don't need to change your post-op instructions for this. The only thing you need to advise them of is that they might feel some particles come out, you know, throughout, you know, the next few days or a week. As long as it's not a big bolus of bone graft material, you don't have to worry about it. A couple of particles is totally normal. So I'll put my patients on usually just a couple of days of narcotics, just so they don't call the office and blow up our phones. We put them on an antibiotic, amoxicillin for 10 days. And then you can use chlorhexidine or whatever you want. I put chlorhexidine because it's the most readily used. I personally use some different products in my office that don't stain the teeth. The big question after people see this first part is, when do I use a membrane? You didn't use a membrane. So here's the deal. You don't technically need a membrane if you have 4 walls of bone. The only time you need a membrane is when you have a breach in either the facial or the lingual plate where you have, communication from the outside of the socket into the socket. That's usually when you need a membrane. Some people still, though, feel like they need to put something over the socket to keep everything in. If you're in that some people category, let's talk to you about what else you can use that's not going to cost you so much money. So here we've got tooth number 10 that we're going to take out. This is the periotome on the distal side. It's going to pop out of there. Kept the papilla intact, grafted the socket. So if you really feel the need to put something over that socket so the particles aren't the only thing you see, what I recommend is getting a piece of this BioStrip, which is kind of like Collotape, but it's coming from BioHorizons. And they come like 10 to a box, and they're gigantic strips. You can just tear off a little circular piece that kind of mimics the top of your socket and place it right over the socket and suture it in. I use a just chromic gut, 4-row chromic gut, figure 8 suture, and that's all you need to do. But that takes care of that for socket graft management. Now, this is what we call the basic socket graft, and there's 4 situations when this basic socket graft technique will not work, and I want you guys to be aware of it, because a lot of times people will send me a radiograft that they've done a socket graft on, and they're like, it didn't work. What did I do wrong? I'd say at least 8 times out of 10, nobody did anything wrong. It fell into one of these 4 situations that I'm about to show you. Number 1 is you took out a tooth and it had a blown out facial plate. You knew there was a blown out facial plate. You knew there was communication from the outside of the socket to the inside of the socket, but we chose just to fill the hole with bone anyway. Just plugged a bunch of this, powder in there into the socket and expected bone to grow. Well, it doesn't work that way. When you don't have 4 walls of bone, you can't just plug the hole with bone. Reason number 2 would be there's no ridge tooth reserve, because sometimes you get these teeth that have such severe periodontal breakdown, there's really no ridge. There's no socket to really graft. There's no ridge to preserve. So when you pluck this tooth out, and once again, there's going to be soft tissue everywhere. So if we feel like you're just going to plug some magic powder into that socket and expect bone to grow, it's not going to happen. Reason number 3, if you see a patient that has a clinical fistulous tract and you take out that tooth, you are 100% of the time going to have a breach in the labial or palatal cortical plate. And we know this because that's where the pus and stuff drains out of, right? It goes through that labial plate. So in a situation like this, right before you even touch the tooth, you know that there's a fenestration or at least or maybe a dehiscence or something. There's some compromise in the facial plate when you see this type of a clinical presentation. The last reason why a basic socket graft won't work is that the bone is too thin to begin with and it needed an augmentation. Now, you would only know this if you had a CBCT. So imagine you're taking out this upper canine and you graft the socket. So what you grafted the socket? The ridge apical to that canine root is only about 5 millimeters in diameter from buccal lingual. So it's only about 5 millimeters wide. And that's exactly what that's all you're going to preserve minus 20%. So, you're going to come back in 12 weeks to a ridge that's about 4 millimeters wide. And you're going to be like, well, that socket grafting technique didn't work. Or that socket grafting, the bone graft material didn't work. And you'd be wrong on both accounts. The problem here is just an improper diagnosis. We didn't realize beforehand because of the CBCT that ridge actually needs to be augmented. It doesn't need to just have a tooth removed and the socket grafted. It needs to be augmented. Same thing with lower incisors. A lot of times these, the way they're shaped and the way the socket's shaped relative to the rest of the alveolar process, we need to graft these things on the outside as well as the inside of the socket. You can't just take these teeth out and plug a socket full of bone. It will not work as well as you think it should. So important points about the basic socket grafting technique is that it has 4 walls of bone. The facial plate is completely intact. So that's why you put your probe in the socket, make sure that facial plate's intact. Once again, a membrane is not needed, But if that makes you feel weird to not put anything over those particles, then just use a little collagen, that little collagen strip there. You don't need primary closure, and you can place your implant or your bridge 8 to 12 weeks after the extraction. So common questions I get is, does it matter what you hydrate the bone in before you graft? It doesn't really matter, but I would highly recommend sterile saline or sterile water, okay? You're going to want, for basic socket grafts, honestly, I told you mineralized cortical bone because it's the least expensive. It's got good packing ability. Whenever you start using cancellous or cortical cancellous for these basic socket grafts, those would work too. You're going to spend a little bit more money on the grafting materials, but those would all three of these would work for the basic socket graft. You're going to use mineralized bone though. And the reason why you're going to use mineralized bone over demineralized bone is because it lasts longer. And with the grafts, size defects like sockets, you want something that lasts longer. Without a membrane, what keeps the graft materials inside the socket? Once again, you can use that biostrip if you want to, but even if you didn't use that, what keeps it inside the socket is a blood clot. So the patient goes home with a gauze pack in their mouth. An hour later, they're going to have a nice bloody blood clot over the top of that graft material because we didn't overpack it, and that's what's going to keep it in place. So I'm going to start off on technique 2, and then I'm going to save the rest for us for part 2. And believe it or not, that's 48 minutes has gone by just like that. So dealing with small fenestrations, 5 millimeters or less. So in a situation like this, I told you guys earlier, this would be one of the indications when you have a fistulous tract where just doing a simple, placement of the bone graft into the socket with no membrane does not work because you have a fenestration here. So how do you go from there, where if you were to reflect a flap, you would see a fenestration like this right on the labial plate. But if you're not going to reflect a flap, how do you go from here to there, with your implant and everything? How did you build that soft tissue? You don't need to be a periodontist to do this. You don't need to have any gum grafting skills or anything like that. I'm going to show you a real quick, easy way to manage this type of a situation. It's called the ice cream cone technique by Dennis Tarnow. So this is great for sockets with small fenestrations that are about 5 millimeters in diameter or less. So how this works, let's just say you've got hopeless teeth numbers 9 and number 10. Okay, you're going to atraumatically remove those teeth. You're going to stick your probe into the sockets and you're going to feel a fenestration, okay? And we're not going to measure the fenestration. You just have a feeling. Is it 5 or less, roughly? That's fine, okay? So what you're going to do is you're going to take a piece of membrane. This is Memblock from BioHorizons, who, by the way, is kind of sponsoring this talk. I should say that. You're going to take one of the membranes. You're going to cut out 2 ice cream cone shaped membranes from that one piece. You're going to stick the cone ends into the socket. Okay, you don't need to shimmy it between the tissue and the bone. Just stick it into the socket, and then you're going to put your bone graft material into the socket. Next step here is you're going to fold the ice cream cone, the ice cream portions of that cone over. Okay, like this. So you're going to go from here and you're just going to fold it over. And then you're just going to do a figure 8 suture with chromic gut or whatever you feel like. This happens to be vicryl. You can use chromic gut is fine. And then that's how you're going to close it. Remember, don't overpack the socket. You got to have some room for the gum tissue to close over the top of the socket graft. This is provisionalized with a flipper. As you can see here, the flipper does not impinge on the papilla. That's the biggest thing, okay? 4 weeks later, you're going to see that the gum tissue likes that Memblock. It's going to go right over the top of it. I always tell my patients allow 4 to 8 weeks for the tissue to overgrow the sockets, okay? Common questions. Why is a membrane needed? You need a membrane because you have a breach in the labial plate. If you don't use a membrane, the soft tissue is going to grow through that hole or that fenestration and invade your bone graft material, and you're going to get that scar tissue formation like I showed you in a CBCT earlier. Will any membrane suffice? The answer is no. You got to use something that's going to last a long time, at least 16 weeks. That's why we use Memblock. It's also a rigid membrane, so you can pack against it a little easier without it tearing. So use something rigid, use something that lasts a long time. So here's an example how this works. So we got tooth number 8 here. It's hopeless. We're going to take out number 8, and you can see where that fenestration was. That's where that granulomatous tissue was sticking out through that external resorption defect. Here's your ice cream cone membrane. It's mem-lock from BioHorizons. It's both rigid and it lasts 16 to 20 weeks. We're going to stick that into the socket, graft the socket, and then fold the ice cream portion over and suture it up with chromic gut. Okay. You don't need primary closure. So for the purposes of today's webinar, you do not need primary closure at all. 3 months later, you're going to open that up for your implant. You're going to see all this bone, ton of bone. And that's based in science and principle. It's not luck. It's not materials. That's just how bone grows. Then we can come back in, place our implant, make the provisional crown, and go to your final. And this is how you manage the socket properly. The great thing about BioHorizons under Henry Schein is that they have a bunch of different materials. So here we've got another external resorption defect for tooth number 9 this time. And for these types of cases, I mean, you could do an immediate implant if you have that experience. But for those of you who want to do things one step at a time, I want to show you that you can get just as good of aesthetics if you stage it, just as easy and just as predictable as you would with a immediate implant. So tooth is going to come out. There's your tooth with the external resorption, as you can see there. You're going to stick your probe in, feel all 4 walls of bone. There is a small fenestration in the labial plate. You're going to stick your ice cream cone membrane into the socket, graft it. This time what we're using, it's mineralized cortical bone as well. It's also called mineralized cortical, mineralized cortical, but the only difference is it's in a putty form. Putties are nice if you get kind of lazy like me. You can it comes in a syringe already pre-hydrated. So all you have to do is just put it in the syringe and squirt it into the socket. Fold your ice cream over the socket and then do a figure 8 suture and close it up. And then you're going to see this 12 weeks later. At 12 weeks, what you're going to notice here, this is what I was talking about. Flipper was a little bit too deep. Okay. For a bridge, you want an ovate pontic that goes 3 millimeters subgingival. But for an implant, you don't want it touching the tissue. So here the flipper was a little bit too aggressive there. And you can also see it was a little aggressive on the distal papilla too, kind of pushed on it. So that's what affects the soft tissue in this situation. At any rate, you can move forward and place your implant. And when you place your implant, you're off to the lingual just a little bit so that you can get a screw retained crown. And that's what it's going to look like. So everything looks pretty good. Not too bad for a staged approach. We love the bone putty also for multiple graft sites, because once again, if you're lazy, it's nice that it comes in a pre-hydrated syringe. You can get these teeth out and you'll see all these sockets. There's 2 premolar sockets and then 2 molar sockets. You can just grab one syringe and just squirt it in there and condense it, just with your cotton tip applicators, and then suture it up. You don't even need a membrane. You're going to come back and have plenty of bone. So important points about this ice cream cone technique is that the socket also has 4 walls of bone. You have a facial or a lingual plate fenestration. Sometimes you have both, but usually it's one or the other. But that fenestration should be about 5 millimeters in diameter or smaller. A membrane is absolutely needed, because otherwise, if you don't, you're going to get soft tissue invagination from the outside of the socket wall into your socket graft. Primary closure, thank goodness, is not needed. All you have to do is a figure 8 suture with your chromic gut, and you're good. As far as time frame goes, you can place your implant 8 to 12 weeks after your socket graft. But I forgot to tell you this, I would absolutely nowadays not place an implant in the front area without a CBCT. I do it every time. Post-operatively, I do the same thing. It's still going to be, whatever you do for pain control. I'm not trying to tell people, to use opioids or not. I personally do for a few days. I do an antibiotic every single time. Technically, you should put people on antibiotics the day before your surgery so that you can get the serum levels up. But in reality, that doesn't happen in our office. It's usually just done the day of. Fortunately, the infection rate for socket grafts is pretty low. I would say in our office, I ran a study one time on how many times I had to do, and supplement antibiotics after this procedure. It was literally like 0.4% of the time. As far as rinses go, chlorhexidine is the most common. If you're going to use chlorhexidine, tell your patient to use it starting the day after surgery. But honestly, if you guys have some other type of product that you like, maybe you're into essential oils, maybe you're into alcohol-free type rinses, those are fine as well. Potential complications. So the only complications that you're going to run into mostly is going to be patients calling and saying, hey, I think I'm losing some of my graft. Remember to let them know that you're going to lose a couple of graft particles. That's nothing to be too worried about. Also let them know that, since it's chromic gut sutures or whatever you're using, it may get a little bit loose. If it's super annoying, they can feel free to trim that, or I always see them if they get nervous about that. A loose or lost membrane typically is not a huge deal. Now, if it's dangling, like let's say you do that ice cream cone membrane, and the ice cream portion of that membrane is dangling out of their mouth, I usually have them come in and we'll just trim it out. Remember that the key part of that membrane is the part that's over the fenestration. That's really it. Most people don't have excessive swelling unless we just beat them up too bad on the, while we're taking the tooth out. I always tell people this too, be on the lookout, follow me on my Instagram. Dr. Curry Levitt and I do 2-day live courses on these things, where we're doing PRF and drawing blood on each other and doing sticky bone and all this stuff. We show a live surgery demonstration. We do pig jaw labs. We do suturing labs. We do all this stuff for you. So be on the lookout. We don't, usually it's in the fall if you guys are interested. But outside of that, keep following me and shoot me a message if you guys have any questions or anything. We're going to have part 2 of this before too long. I can't remember the date of it, or I would tell you, but yeah, like I said, just keep following me and I'll keep you posted. But part 2 is going to encompass, what do you do if you have a full blown out plate, if you have a nasty infection, a lot of granulomatous, disease in the periapical area. How do you get primary closure? How do you adapt a membrane? If you look at my latest post on plaque China, for example, you'll see what I'm talking about. How do you adapt a membrane and suture it and secure it into place? So that's what we're going to be talking about next. So with that, I appreciate your time. I'm pretty much right at 1 hour. So
you did a great job. Thank you, Dr. Wong. That was a great presentation. And we already have questions lined up for you.
Fire away.
All right. So our first question reads, how do you avoid the suture getting engaged with the membrane and pulling the membrane out? And if the membrane does pull out, what would be your approach, like in the case of the Tarnot technique?
Yeah. Okay. So that's an actually easy question to answer. So your membrane is on the inside of the socket. So when you're engaged, you always go through the labial side first of the soft tissue. Your tissue, the tip of your needle is going to actually hit the labial plate first. So you'll hit the labial plate and then slide on up. Your membrane's on the inside of the socket, so that should never be an issue. If for whatever reason it's still an issue, I couldn't imagine how that would be. But if it is, what I would do is make your first bite off laterally more, off to the mesial or the distal. So get away laterally away from the membrane. I'm trying to think here. I'm still reading here. Got another good. I'm just reading the chat here. So let's see. I've got a question about Ossix Plus. Ossix Plus membrane is there's Ossix comes in a grafting material as well as a membrane. You can't use Ossix plus membrane for the ice cream cone because it tears too easily. As soon as you touch it or try to manipulate it or even push on it, you'll rip a hole in it. As far as the grafting material goes, I'm assuming we're talking about Ossix bone. Good grafting material, probably just a little unnecessary for the expense of it. But it is very practical. It's just that the cube is so small, you can't do a whole lot with it unless you buy the bigger cube, which is going to cost you a little bit more money that you don't really need.
All right. Thank you for that feedback. Our next question reads, is it ever indicated to wait to socket graft when there is a large infected area with significant amounts of granulation issues?
Wonderful question. Love this question. We get it a lot. So, and to be honest, if you ask me, I still graft the same day. But if you ask some other people, they'll say to do a delayed approach. We're both right. It's whatever works best in your experience and in your hands. The safe bet, if there's a lot of purulent exudate, a lot of bleeding and oozing, some people will just take the tooth out and get the infection cleared out and then come back usually within 4 weeks to finish up the graft part. And if you want to do that, that's totally fine. It actually does have some benefits because you'll get some soft tissue healing and coverage over that by then. So that's one good way to do it. I usually just graft it anyway, just because, I'm trying to minimize patient appointments and that type of stuff. Just being a specialist, they don't want to come here that often. So that's just me. But the safe bet is to stage it if you're so inclined to do that. So.
Okay, thank you. Our next question is from Melissa, and she asks, when you place the ice cream cone in the socket, how do you get the ice cream part inside the socket after the socket is filled? Do you underfill the socket, or how do you go about that?
Yeah, so the cone part goes in first, right? The cone part goes in first over the labial, basically patching the fenestration. So it actually goes into the socket. So and then you graft the material and adapt basically the ice cream cone part up against the wall and the fenestration. So you're packing that socket. At that point, the only thing you should have left over is the ice cream, the ice cream part, right? And then all you do is you just fold that over the top. So there's really, you don't have to do anything. It'll just fold over. And because it's Memlock, once it gets wet and hydrated, it should normally stay down. And if that doesn't work, your figure 8 suture over the top will cinch it down. So I hope that answers that question.
Thank you, Dr. Wong. All right. Our next question reads, is there a way to tell when the graft matures? So they asked because they once opened a socket preservation after 4 months and the material was still soft.
Yeah, if that happens, usually it wasn't degranulated properly enough. So you still have a lot of granulation tissue in there. That happens. The other thing could be a different type of graft material. So as an example, if you use a particle size that's too small, and we use small particle size graft materials all the time, but just not for sockets. But if it's too small, then it disappears too fast. So you end up getting more soft tissue in there, or the opposite. Sometimes the particles are too big. Or sometimes it's a synthetic, or sometimes it's bovine. As an example, bovine materials do that a lot to where it just hasn't turned over into bone yet. So it's going to be a number of different possibilities.
All right, great. And we have 2 more questions, if that's okay with you.
Yeah.
Okay, perfect. So this person asks, how do you feel about only using PRF as socket preservation?
I think that's fine. For a basic socket graft, you could absolutely just use a PRF plug and do just fine. I think that's not a problem. Now they have different forms of PRF that last a little bit longer as well. So those might be worth looking into as well. So.
All right, thank you. And our last question is, how common is it for patients to not tolerate standard cadaver bone, and how would you know how to do an autograft instead?
It is not common at all for a patient to not tolerate cadaver bone. You know, it's acellular. It's already processed. It doesn't elicit really a measurable immune response. So I definitely would not have not encountered that. And so at all, actually, for a socket graft, I can't think of too many times where I've used an autograft for that reason. I do give some lectures for Henry Schein where we talk about using autografts, you know, for soft tissue, you know, healing and things like that. But yeah, cadaver grafts are very, very well tolerated for sockets.
Okay. All right. Thank you. Dr. Wong, thank you so much for the great presentation this evening. If anyone does have any outstanding questions, you have his Instagram right on the screen where you can message Dr. Wong directly. You can also email us at webinars@henryschein.com and we can get them answered for you. And as a thank you for attending, everyone will receive the recording via email in the next week. So thank you all for joining us. And thank you, Dr. Wong. We look forward to seeing you on future webinars.
Hey, sounds good. Thank you, guys. Appreciate your time.
Thank you. Bye.
Yeah. Bye-bye.